Okay, guys, so I think we're going to start just in the interest of time. Welcome to the Calgary ED COVID update number 3. Thank you for joining us. I would like to introduce Dr. Eddie Lang, the Emergency Department Head, for the leadership update. Eddie?
Thank you, Stuart, and good morning, everybody. I hope you are all enjoying my background here for this little brief update. What I thought I would do is share with you some cautious optimism that I'm feeling at the present time, which is becoming increasingly optimistic and less cautious. And I'm going to do that by addressing 2 topics. The first is about our department, and more importantly, perhaps the zone's preparedness for the COVID pandemic. And then I want to just touch on some of the modeling that has been circulating quite a bit through public channels and through AHS channels. So when it comes to our department, I think there's really no question, and I'm totally flabbergasted by the site leadership, Neil's amazing coordination of the COVID response, and how everybody's coming together, be it from the SIM airway preparation perspective to wellness to all of the incredible volunteerism and activity that's happening. But what about the zone? Well, let me relay some data that came through on yesterday's ZEOC call. So firstly, at the moment, we have 25 COVID patients, roughly 25 COVID patients admitted in hospital across the zone. That is mostly inpatient. About 40% are in ICU, and about 2/3 of the ICU patients are on vents. But what is the capacity? What are we prepared for? That's really an incredible figure. We're currently sitting at 70% capacity. That's 30% empty beds. That's hundreds of beds across the zone that are available to us. And as you're aware, by working in the Emerge, and this is an international phenomenon, we are seeing 36% less volume for a variety of reasons, which is translating into fewer admissions, elective surgeries are canceled. So all that is creating incredible capacity. So, I mean, that's just one example of how the zone is prepared for this, but it covers all other areas as well, including upscaling SWOT testing and all of the work that you're going to hear about soon on the PPE front. I just want to switch gears, and maybe Stuart or Aaron, you can bring up the modeling slide. A lot of you have seen these projections presented last night by Jason Kenney, and you know, these are really, in some ways, they're encouraging because they tell us that even in the worst case scenarios, we're going to have sufficient ICU and inpatient beds, but they're also still quite frightening. And what I wanted to do is just put a little bit of a behind the scenes spin on this. You know, these estimates depend entirely on what is believed to be the case transmission rate. So each case will then go on to infect how many others. These models are largely based on the idea that each person will infect 1.5 to 2 additional people, give or take, given the probable elevated and extreme. But those are really assumptions or best guesses and don't really account for what the impact of the distancing measures may be. So what I'm thinking about and what I've been able to learn about, and the link to the relevant data is in the chat window, I thought I would try to touch base with some colleagues in Washington State. I had a really good discussion with Michael Sayer, who's an Emerge doc at Harborview Hospital. Washington, as you may know, is the first American epicenter for the COVID outbreak. They are currently sitting at 3,000 cases. That's triple the, or close to triple the Alberta average. They unfortunately have lost 300 and some odd individuals to COVID. So they're way ahead because COVID landed there far earlier, but their distancing interventions and the things that they are doing are really similar to where we are. So Michael was kind enough to speak to me while on shift at Harborview, which is a huge, busy county hospital in Seattle that serves a population in Kings County of 2.3 million. And what he described to me was fascinating. Even at their stage of the pandemic, the emergency department is really quiet. The hospital is empty. They're not empty, but 2/3 full. They've got tons of capacity. There's not a single emergency department in Kings County that is boarding patients, and they're talking about shipping ventilators to hard-struck states in the eastern U.S. And if you look at the pandemic curve that's in the link, there's clearly evidence of flattening. So all that to say that I'm incredibly grateful to all of you for the amazing effort and work. But I think if we look at the situation as it's evolved in some other jurisdictions, we have very good reason to be optimistic. So I'll stop there. Happy to chat offline, take questions, and we'll turn things back to Stuart.
Thanks, Eddie. Just again, thank you for all the good work that the leadership and admin team are doing in the background. We really appreciate it. Thank you. Can we have the next slide, please, Aaron? So just to give you a quick idea of what we're doing, we just had the leadership update from Eddie. Today's going to be a Q&A format. Just please remember when you go to the questions, we were having some issues potentially with Zoom bombing, but if you go to the questions, we have opened them to everybody. If you have a question, look to see that somebody hasn't opened it, asked it already, and then you can upvote it. And Sean will be correlating the questions, and we'll be addressing the top questions in the Q&A section at the end of this talk. We are just going to talk about some resources, and then this is going to be on a Q&A question from the questions that you guys posted to Catherine Crowder initially in the last couple of weeks. And then we have a few guests. Catherine Linton from IPNC and Dr. John Connolly will be joining us again. And then finally, we'll be wrapping up with a wellness update. Okay, the next slide, please, Aaron. And so these are the resources. These will be available, and we will link them all to the notes. But just be aware there are lots of great resources out there that answer a lot of our questions, and some of them were included in the newsletter. So please go back and look at those resources again. Next slide, please, Aaron. And so I'm just going to introduce Catherine. Catherine Crowder has been our PPE and IPNC link for the working group, and she's going to take this next section of slides. Catherine?
Hi, thanks, Stuart, and thanks everyone for joining us this morning. I have a few slides that I'm going to go through here before I hand over to Kat Linton with IPNC. I just want to kind of go through some of the basics, and we'll try to answer as many questions as we can that's been sent in. First of all, the PPE recommendations that we use in AHS come from very reputable sources from the Public Health Agency of Canada and the World Health Organization. And of course, everybody knows by now that the recommendation for protection for PPE with suspected COVID-19 patients is contact droplet precautions, with the addition of airborne precautions using N95 masks for aerosol generating medical procedures, which we all know what the list of aerosol generating medical procedures is, so I won't dwell on that. Next slide, please. Now, you may be familiar with a study that's cited frequently from the New England Journal of Medicine in March of 2020, looking at the viability of the COVID-19 virus on surfaces. Now, the caveat here is that fabric was not specifically tested, and so this opinion is from one of our local infectious disease doctors' opinion. But the question comes up a number of times around our clothing, our scrubs, our uniforms, and how long can this virus live on our clothing? And the answer is, we're not really clear, probably a couple of hours. Interestingly, the virus can be a bit more hardy on things like stainless steel and plastic. It's been found to be viable for up to 72 hours on these types of surfaces. So all this to say, if you are considering reducing the risk of sort of fomite transmission, think about things like your wristwatch or intricate rings that are difficult to clean with hand hygiene, and reconsider wearing those things to work. Next slide, please. This question's come up a lot, and according to AHS officially on scrubs for specific practitioners, the emergency department is included in the list of people who are eligible to wear AHS issued scrubs. Now, practically speaking, there may be some issues around the availability of scrubs, and this is a current active discussion at a leadership and at an individual hospital level. And so the answer is maybe scrubs are available, but currently keep doing what you are doing in terms of what you are wearing to work, and we will clarify this as time goes on, as soon as we know. Next slide, please. We received lots of questions about double gloving, and if you kind of search the internet, there's lots of interesting donning and doffing videos from various sites that really push the use of double gloving, and the answer is no, we shouldn't be double gloving. Double gloving was originally intended for procedures where there's a high risk of glove punctures, such as certain orthopedic ORs and things like ED thoracotomy. So if you're anticipating doing an ED thoracotomy on a COVID patient, please do double glove. But the principle remains that the more PPE that is donned, the more likely you are to self-contaminate when you doff your PPE, which is really what the risk is to healthcare practitioners. Further to that, please don't apply alcohol-based hand rub to gloves or wash gloves. Just doff your gloves and clean your hands. Next slide, please. So this question came up a lot as well, and I will sort of answer this question with the disclaimer that this is a bit of a moving target. So in line with AHS's guidelines around home PPE, it is not recommended that people use any home-based PPE that's not been approved by AHS and by extension approved by Health Canada for safe PPE. Now, specifically with respect to face shields, there are guidelines about the length of the shield, the angle of the shield, the type of band that is used to secure it to the head. There are specific guidelines about that on the Health Canada website, and we've included that in the resources. However, we recognize that there is some work to be being done to procure PPE from various sources in Alberta, and that's happening more at a political level and with leadership with AHS. So we will keep you posted if any of this changes, but the current advice is to use AHS supplied PPE. Next slide, please. Now, this is also probably
Can you hear me?
Yeah.
Are you able to hear me?
Yeah.
Yeah.
Is this Dr. Conley joining us? Great, thank you. So this is probably the most frequent question that I received, and how do we protect our homes and families from unintended fomite transition of COVID-19? And the basics still apply here. Frequent hand hygiene, careful hand hygiene, proper use of PPE, donning and doffing of PPE properly is what is going to keep you safe. Now, with respect to the clothing and shoes that you're wearing home, it's quite reasonable to, if your clothing is soiled, if your shoes are soiled, to, you know, remove your shoes when you come into your home and wash your clothing as you normally would. But I want to stress and for people to remember that there are other things that we bring back and forth to work, like our travel coffee mugs, our stethoscopes, watches, jewelry, etc. And consider those as fomites as well if we're concerned about fomites coming home. And think about leaving those things at home, like your travel mug and your watch and your jewelry, things like that. Think about a safe storage place for your stethoscope that doesn't come into your home. Next slide, please. And finally, from my slide's point of view, practice PPE donning and doffing. So a lot of work has been done to create some practice sessions for ED staff. Now that includes physicians, RNs, RTs, PCTs, everybody who practices in the ED environment, to have a session to practice donning and doffing PPE safely. Now, there are some checklists that sort of PPE champions have developed to provide some feedback about your donning and doffing of your PPE, as well as give you insight into common occurrences where PPE doffing safety is breached, and Kat Linton is going to speak a little bit more to that. These are quick sessions. There's multiple sessions set up. Please email myself or your site leadership or your IPNC, and Kat's going to talk to this a little bit as well, to include yourself in these sessions. And we're also using a bit of a train the trainer approach, where people who have been directly trained by IPNC can also disseminate that training to local staff. And it's really good while volumes are low to get some practice doffing your PPE. The other thing that I want to thank Sean Dowling for coining this term is think about employing a PPE dofficer, particularly around the time of AGMPs, where we have a team organized. A PPE dofficer can be anybody who is comfortable and confident in doffing PPE and can watch and supervise others doffing PPE. So I encourage you to access these resources and consider getting some practice donning and doffing PPE. Thanks.
Thanks, Catherine. Thanks for all the hard work you did getting this presentation together. So I think we're just going to change up our schedule a little bit. We were going to go to Kat Linton for the next, I think, 6 slides, and then to John Conley. But I think let's, in the interest of time, maybe we could just, Aaron, if you could just jump down to John's slide. John, welcome. Thank you for taking time out on your very, very busy schedule. You seem to be everywhere these days. So thank you for finding some time for us.
Thank you. Can you hear me all right?
We can hear you great. That's excellent. Just
one comment before the first question. As for the officer, if you have the COVID app, which if you're with Spectrum MD, Spectrum COVID app, it actually gives you a digital officer, because the video and also the broken up stages of the doffing procedure is very nicely displayed on both iOS and Android formats. So you can have your own individual officer to very quickly review it before you have to go in and do your doffing. So I just wanted to point that out. If you don't have the Spectrum COVID app, there are now between 3,000 and 4,000 users across the province. Over.
Oh, that's excellent. It's such a great resource. So John, just what we're going to ask you to do is address some of these, I think, pretty topical and maybe difficult to answer questions that we have on the slide here. These have come from our group. And then we have the next slide, which is from the Premier's presentation last night, talking about resources and what that looks like. So I'm not sure if you could speak to that as well. But what I might do is just leave you with the slide, and if you could run through these questions and answer them for us. And if obviously if there is no clear answer, then I mean, you'll tell us that. Does that work? Is that okay?
Perfect. So I'll just start right in. This is a closely guarded secret, but with respect to the PPE, but to my knowledge, we have adequate PPE at the current time. We do need to move forward in terms of looking at projections and do the modeling in terms of where we're going to be, particularly with the projections as we move forward into the rest of April. Just to give you an example, and I think I mentioned this on a previous call, in Switzerland, a country of 8 million, we have 4 million in the province of Alberta at the peak, where they had 300-400 patients in each of their major city hospitals across the Switzerland, Zurich, Geneva, Lucerne, Basel. They were running through 1 million N95s per day. So it is a real issue, and we've seen global shortages of N95s. Calgary is probably at a faster burn rate than Edmonton, given we have 2/3 of the cases that are present. We do need to worry about U.S. supply chains. We saw the friction with President Trump about 3M and America First. I'm still worried that the majority of them will go to the US as they ramp up in some major populated northeastern states, and then California picks up steam, and then the southern US as well. There will be a major shift. So I'm not certain that I trust the supply chain to provide us with the number of PPE. We are actively working on multiple PDSA cycles with a group including the CPSM, that's Procurement and Supply Management, also with the sterilization group, SPD, IPC, and Workplace Health and Safety. And we've engaged the laboratory of Dr. David Evans, level 3 at the Lee Cushing Virology Institute in Edmonton, and they're hoping that by tomorrow they will have completed the experiments. We've done rapid PDSA cycles and have shown that the N95s, the 1870s, which are 3M products, do very well with a genteel steam gravity cycle, which is about 30 to 40 minutes, and reaching a temperature of 200 degrees Fahrenheit. And the fit testing looks great. They come through, and the 80+% of them fare very well. We're experimenting with lower temperatures. Dr. Evans believes that this virus is so susceptible you could go to as low as 60 or 65 degrees Fahrenheit and still kill it. But those experiments should be done at the end of the week. And they've already started looking at a recycling bin process, starting with PDSA cycles in the ICU and the OR, because they already have cycling. ER maybe next, because we do know that there are a number of N95s that are being used, and we think that we'll have a made in Alberta strategy fairly quickly. A study just released from University of Manitoba using the NML laboratory, the level 3 there in Winnipeg, showing the same thing. And it does appear that both Steris, which is the vaporized hydrogen peroxide plus steam sterilization, seem to work very well. There's some question about UV light. It might affect the particle penetration capabilities within the N95, but the steam is looking very good. We're just got a couple of final items, which is the engineering particle check, but for filtration capacity, but we do not expect that that's going to be a barrier, and we'll have met all 4 requirements to allow a recycling process to occur. So I think a bit of a good news story there. And yes, you can use N95 masks past their expiry date, because there was a bulletin that came out almost 2 weeks ago now from Health Canada, and it's on the PHAC website, that yes, you're able to use them with the 4-point check with respect to the straps, the integrity, the nose piece. So that's been around for a while, but I'll tell you, it's if you didn't know it, don't worry about it. There are major communication issues that don't sometimes get through to everyone. So I think that covers most of the issues surrounding the PPE. There are also other groups in Israel looking at gamma radiation, which appears to be very promising. And also in Brazil, they've been actually taking their medical surgical masks and they're putting them in an oven at 70 degrees for 40 minutes, and it looks to be effective as well. So there may be multiple methods to be able to provide, I don't want to use the term homebrew, but well-validated, scientifically valid procedures to recycle our N95 and medical surgical masks. Over.
Thanks, John. That was very helpful. Erin, can you show us the next slide? So John, just looking at this slide that the Premier presented last night, I mean, from what I'm hearing you say now, I think that the recycling process will hopefully be able to mitigate this potential. My understanding, maybe if you could talk us through this, your understanding of the slide. But my understanding is that at this possible time, we're going to run out of masks in N95 at the end of June. But from what you're saying with the recycling, that will be less likely to happen. Is that correct?
Correct, and I think that's important to be able to bring that forward, because this may be a moot point if we're able to recycle. I've asked that they look at the inventory. The bit of good news, if the steam gravity cycle works, we have 110 facilities across the province. The vast majority of them have capacity with steam sterilizers, because it is something ethylene oxide was sort of phased out. And if you think about that, I've asked that this group, because I'm a member of it, that we run up to a capacity that we could do 500,000 to 1 million N95s per day. as a combination, and that is the target that we're looking at. So if we extrapolate from what they were going through in Switzerland, this is a worst case scenario where every encounter a person is using an N95, that would put us way over a threshold. They are working to see if we can mobilize all of these steam sterilizers across the province of Alberta, and or in combination with Steris, which is a much more involved process. We did find some odor issues following that, but we're looking aggressively at steam sterilization with the more genteel gravity cycle. And we have a lot of capacity in Alberta. So that might, if we can ramp up to the figures that I'm hoping that we can, that would give us some considerable reassurances. The one thing we don't know is how many times. McMaster has done some studies suggesting you can recycle up to 10 times. We're looking at potentially 2 to 3. So we'll see where we go with this, but I think I'm not going to spend any more time on this slide trying to explain it, partly because I don't understand it all, but also because as a moot point, we may have come to a made in Alberta solution for this. Over.
Perfect. John, just one point on the slide that I just maybe to clarify, face shields coming up there that we would not have enough. Could I get your take on face shield versus goggles? And that has been a question raised.
Either or are suitable. And just to address some of these other things with respect to gowns and coveralls, they're recyclable. They wash them, through K-Bro, so less of a concern unless they get ripped and torn. With respect to face shields, another strategy that has been going on is the procurement of face shields from elsewhere, and then also work going on at the university in both engineering and EVDS, where they are looking at 3D printing, and they've got contact through the city of Calgary with at YYC 3D printers. There are over 300 individuals, groups who are able to look at 3D printing if they ramp up, so that we may be able to 3D print. We've sent them goggles and face shields of various types, and they're inventing their own, some of which don't work that well. But there's active work going on, and a very great contribution right through the city of Calgary, right up to Chief Tom Sampson and the mayor. We're looking and engaged about this process. And similarly, alcohol-based hand gel disinfectant, Canmore Brewery is already producing them in cans using the WHO publicly available WHO formula. So I think we also have a local solution to help us with the alcohol-based hand gel disinfectant. So for those of you who weren't aware, great deal of work going on in the background. And I think there was some planning going on that, and I've said this before, hockey analogy, we need to be where the puck is going, not where it is now. And we took that approach 3 or 4 weeks ago. So I think it's hopefully putting us in a good position as we move forward. Over.
Excellent. It's good to know you. Good to know you keeping us ahead of the curve. Thank you. Can I just ask one more question, John, around masks and wearing them in daily practice at work, work outside in the community? Are you wearing a mask?
I'm going to answer that by saying I was on call all weekend, and I was not. I do my own point of care risk assessment. If I see somebody from the homeless population, for years I wear a gown, gloves, and mask because they could have lice or scabies or any other number of things, and they're not always the most reliable historians. I'm sure that's no news to you in the ER department. There was a permissive mask policy that came out last week suggesting that if you wish to, you could wear continuous use of masks. I understand that there is a new program that's going to be coming now through ECC in the next day or two about a continuous mask use policy. Many of the other provinces have adopted it. BC has gone further and they're using complete PPE. That has to be balanced, and you need a well-balanced approach with respect to your supply and management issues, because if you are too aggressive, you run out. But I know that they're going to be looking to a more fulsome continuous mask in interactions within a 2-meter range of the patients, and still using a point of care risk assessment and masking any patients that have cough, sneezing, or other ILI symptoms. So I expect that that's going to be coming out. How much compliance we'll see with it, I don't know, but that is going to be a recommendation that I understand will be coming from ECC, and it's on the premises that there may be pre or polysymptomatic healthcare workers that might be capable of transmitting virus to vulnerable patient populations. I know in the ER you may think of it on the opposite extent, but it is something that I think we are going to be seeing in the next couple of days come forward. So I still am a believer in ensuring that you take a good history and do your point of care risk assessment based on the patient that is that you're coming into contact with. But that matter is out of my hands now, because I think the ECC is going to be sending out a recommendation for masking, but with some good policies around it, you know, not when eating or drinking. The WHO came out with a document up to 6 hours of continuous use, but if you go in and out of a room with someone on contact droplet precautions, you could be we still have influenza circulating, for example. You could be having it transmitted to others, and it's also important to care for the mask carefully. You can't wear them around your neck like a piece of jewelry, and similarly your use of your goggles or safety glasses, they need to be cleaned, and you need to be cognizant of not touching the external surface. Recent studies are suggesting you can get accumulation of particles that penetrate through the mask. And obviously, if it's soiled wet or damaged in any way, you have to change it. So this is going to increase our burn rate for medical surgical masks in a big, big way. Over.
Thank you, John. That was great. I think we've used up a lot of valuable time. We are going to have Kat Linton do her presentation now, and then there will be a question answer. I'm not seeing any particular questions coming up for John right now, but thank you. You covered a lot of ground, and we really appreciate your input.
No, thank you.
Okay, so moving on to Kat. Kat Linton is a infectious disease professional based out of the Rocky View, and has been very open to helping us with this talk. Thanks, Kat.
Hi, no problem. Can you hear me?
Yes, can hear you well.
Great. Thanks again for having me. And I just wanted to speak to a few topics that were brought up to Catherine and the team, and just answer a few questions. So there's lots of questions regarding what types of wipes we should use for various products. And in infection control, we do recommend that the type of wipe you use is the one that's approved by the MIFU or the manufacturer's instructions for use. Most of these wipes are available in our emergency departments, and they almost all of them have a 3-minute wet time. And so what that will mean will be vigorous scrubbing of all the surfaces and then allowing it to air dry. And so as long as you can do that and allow it to air dry till it's completely dry and the 3 minutes have elapsed, then you can use it again on either the next patient or take it with you wherever you're going. And so that's for non-critical equipment, and that's part of the Spalding criteria. Obviously, critical and semi-critical equipment have higher levels of disinfection and sterilization criteria. So non-critical equipment would include things like your stethoscope or other in between patients equipments, glucometers, blood pressure cuffs, those types of things, anything that comes in contact with intact skin. Okay, next slide. Okay, so we also had some questions about what are common PPE breaches of safety. And so the big thing I'd like to say here is that any improperly used PPE is wasted PPE. And so in light of what Dr. Conley and the modeling is predicting, we need to make sure that we're using our PPE properly. And so a few different things that we see, you know, based on human factors is touching or manipulating your PPE during use. And so obviously it's uncomfortable sometimes to wear a mask or eye protection or something like that. But anytime that you do come in contact with the outside surface of your PPE, you're risking personal contamination. So try to avoid doing that. And one of the best ways to do that is to make sure that your PPE is on properly from the get-go. Again, touching your face or your mask or your eyes. This is a normal human habit. So we just want to make sure that we are really aware of what we're doing. And then as well, for those people who have longer hair, we want to make sure that it's tied back appropriately prior to our PPEs as well. Neglecting hand hygiene before or after. So I just wanted to mention PPE are clean supplies, and anytime we access clean supplies, hand hygiene should be done before we access them, and that will keep our supply clean. And then after we're taking off our PPE, or especially our gloves, it's often missed because glove use is not a substitute for hand hygiene. So we really want to make sure that we're always doing our hand hygiene after glove use. as well as after we doff all of our PPE, because we're doffing contaminated equipment. So I've highlighted a few common wearer errors. So wearing your mask around your neck, safety glasses on your head, not tying the waist appropriately. And again, these are all not only inappropriate use of PPE, they're not protective, as well as increasing the risk of personal contamination. Okay, so that's a big spiel about how to wear, how not to wear PPE, but on the next slide, you'll see some common key practices and principles that we want to put in place to keep ourselves safe. And so doffing or taking off PPE should be done in the appropriate order, and it should be done in a controlled manner and a deliberate manner. So when we are taking off our PPE, we always want to try to avoid as much as possible touching the contaminated side of the PPE. And we want to make sure that we're doing our hand hygiene after every step. In keeping in the principle that our PPE is contaminated, we want to avoid re-inoculating ourselves by bringing that back. All single-use PPE should be discarded immediately after use, whereas reusable PPE needs to be decontaminated before reuse. So never use single-use PPE again without it, or reusable PPE without being decontaminated between uses. Next slide. Okay, so do we need extra PPE for protecting our necks, chin, lower legs, shoes? So we get lots of questions about protecting all of the areas that we haven't typically protected before. This includes hair, but what we want to really remember for this pathogen is that it's a regular contact droplet pathogen, and there's been no indication that these areas have been implicated in transmission. Sometimes wearing additional PPE can be a risk for personal contamination because doffing technique has to be proper. And so one of the things we remember during a pandemic is we try to keep everything as close to normal as possible. And so we would not want to introduce new PPE unless it was absolutely necessary and there was documented evidence of transmission, and that specific type of PPE could be preventative for. And so we have to just remember certain regular routine practices. The things that we're taking to and from the hospital should always be clean, just like Catherine had said. Yes, we always consider our shoes are dirty. The floor is considered a dirty space. Any time that we do have gross contamination on our personal items, so either our scrubs or our shoes or our watch, we want to make sure that those get removed and decontaminated as soon as possible. And so this just kind of mentions why we don't need the shoe covers as well. Next slide. I don't know if you can hear my sweet daughter in the background, but hopefully not. Okay, so this slide speaks to the need for head coverings or not. And again, we don't encourage the use of head coverings if at all possible. Again, they don't have any permeability claims, and they don't have resistance to droplets or splashes. The reason that people do use head coverings in certain instances is to prevent their hair from falling into a sterile space. So that's why it's worn at certain times. It's not necessarily PPE use, but it's more of an engineering control to prevent contamination for your patient or for a sterile field. Okay, so eye protection, we do get this question a lot. Do we use one or the other or both? And basically what we want to do again is follow the principles for choosing our personal protective equipment. They need to fit us properly. That's the personal part of it. And they need to protect us from our anticipated trajectory or our anticipated hazard. And so as long as your eye protection is fitting you, which is covering the entire eye area, and it's going to be protective against your anticipated trajectory, then it is going to be the right type of protection for you. And then so one thing I just wanted to mention as well is typical prescription glasses do not meet WHS regulations, and so you need to have eye protection above and beyond your regular eye prescription glasses. We do sometimes clean and disinfect reusable eye protection, and I just wanted to mention quickly how to do that. So you would take a low-level disinfectant wipe, so one of the examples of the wipes on the other page, And you would want to clean the inside of your eye protection first, and then the outside of your eye protection. Again, you want to clean it vigorously as to remove that potential soilage, and then allow it to air dry. So inside and then outside of the eye protection. Next slide. Okay, if we're using continuous surgical mask, how often should we change? So the same principles apply to surgical masks as well as N95 masks. So they should be changed when they're wet or when they're soiled, or if they become damaged. And so it's not necessarily a time frame, because users and the procedures that they're being used for are all of different durations. So a few things that I want to mention is when you're accessing your N95, it should be the one that's on your fit test card. You should also make sure that every time you put your N95 on that you're doing a seal check. And so that's a forceful exhalation with your hands kind of around the edge to make sure that you don't have any active air leakage. So again, readjust if you do, and then try the seal check again. And so you should also be removing your masks as per proper doffing technique whenever you're going to be going on break, whenever your risk is no longer there, whenever you're going to be using other pieces of equipment that would be coming to your face, for example, a phone. And so I just wanted to mention that when we're doing it, we always want to do our hand hygiene first. So anytime we're going to be using continual PPE, we don't want to become complacent and fall into our regular human factors. So if we're going to be doffing our masks in non-normal places, so normally we would be doing it outside of a patient room, but now you might be doffing before you go into the staff room or doctor's lounge, or before when you're at the nursing desk, before you're going to answer the phone, those sorts of things. We always want to make sure that we're doing our hand hygiene prior to doffing. So that's just a quick thing to keep in mind. Anytime we're going to be bringing our hands towards our face, we want to be doing our hand hygiene. Okay, next slide. Okay, that's it for me. Sorry if that took a bit longer than anticipated.
That was great. Thanks, Kat. That was cleared up a lot of questions. So we're going to move to the Q&A. Thanks for joining us. I think you already cleared up quite a few questions, and I know you're going to stay around for the Q&A. I'm going to hand over to Sean, who's been looking and moderating questions. Lots of activity, lots of great questions. Sean?
Actually, amazingly, there's only one question that seems to be not fully answered so far. And that was a question around cell phone usage. And what's the best way to protect our cell phone, whether that's to wipe it off after each usage or putting it in a plastic baggie and wiping off the baggie. Could either Catherine or Dr. Conley or Kat address that question, please?
Yeah, I can speak to that. It's Kat here. I'm not sure if Dr. Conley is still on, but just like our hands, the best thing to do would be to eliminate the contamination using a low-level disinfectant. So when we think about the hierarchy of controls, the highest hierarchy control is elimination. And so that's far above PPE, which is actually the lowest level of control. If you kind of Google hierarchy of controls, you'll see the different options we have in the hospital. And so the best way to actually protect yourself is to eliminate the bacteria or viruses, which in our case for the cell phones, it would be to wipe them down. Using a substitute or a kind of cell phone PPE, like a plastic bag, is not great, because in that case, again, microbes could come through, they're porous, they would get reused. You're just transferring bacteria between different environments. So again, just like our hands, it's better to low-level disinfect them.
Excellent, thank you. Thanks, Kat. Any comments from any of the other panelists on that? Another question that just came up from Colleen around a specific reusable respirator, the 3M 7500 reusable respirator. Is this going to be approved as it may help conserve N95 supplies? I know it's already been discussed that only AHS approved PPE should be, or AHS provided PPE should be used at this point, but anyone want to address that specific question?
Hi, this is Kat again. Sorry, my answering machine was just going off, so I just want to step in too soon. I can speak sort of, I guess, vaguely still about this. Those special respirators do require special training and special fitting. And so right now they're not being suggested or approved for use by AHS.
Okay, there's also a question specifically around stethoscope cleaning, and there was some discussion back and forth in question and answer about whether to use the stethoscope in the room or your own, and if you're to use your own, how to, or even the one in the room, how to clean it after usage.
Okay, so there's lots of different ways that units have configured this. So some units actively use stethoscopes in rooms and some practitioners still prefer their own. So I'm going to touch on both. There's no one right way because we do have different setups in the hospital at Rocky View and throughout the province. So when a stethoscope is in a room and it's for multiple healthcare workers, you always want to be cleaning that stethoscope before you use it because that's going into your ears. So again, you would low level disinfect the entire stethoscope. If it's grossly soiled, you need 2 wipes. And so you would wipe it down first with to be the cleaning step, and then the second wipe would be the disinfecting step. And that's only if it's grossly soiled. And then again, you'd want to do that after use before you hang it up back on the hook. Now, if you're using your personal stethoscope in the room, you would want to avoid putting it back on your neck. You would want to carry it out with you and put it on a dirty spot. So either a dirty table, lots of units are getting these things called dirty tables, which is a designated area for dirty equipment. Then you would doff your PPE appropriately and can follow to low-level disinfect that item or the stethoscope in this case after you have exited the room, and making sure that you're also low-level disinfecting the area which you place the dirty piece of equipment. Does that answer that question, Sean?
Yeah, no, I think that's great, and it probably speaks to maybe the need for our department to have a more clear process.
Yeah, and so typically stethoscopes are cleaned with the alcohol-based wipes. So that's either the little alcohol swabs that you see sometimes for taking blood or labs, or you could use the Kimtech wipes. And typically Kimtech wipes are also safe for electronics. So I did get a message privately asking about which type of wipes for cell phones. Again, I should always say defer to your manufacturer's instruction for use, but typically Kimtech or alcohol-based wipes are safe for electronic use.
Yeah, Kat, maybe you may have briefly touched on this already, but do you want to describe the sort of CAVI wipes when they would be the preferred option versus the Kimtech wipes, which you just described?
Yeah, so CAVI wipes are a bit of a harsher wipe. They're the chemical is a quaternary ammonium compound, whereas the Kimtech wipe is an alcohol-based compound. Now, additionally, the most common wipe we see in the hospital is the Excel wipe, which is an accelerated hydrogen peroxide, which has a really high level of compatibility and is really great. The reason we use Kimtech wipes on electronic equipment is because it helps, the screen does not become foggy and it doesn't affect the readings for things like SpO2s or glucometers. Typically, we use Excel for almost anything else. It has really high compatibilities, and we kind of have gone a bit away from CAVI wipes, but they still are a safe low-level disinfectant for use on a wide variety of products.
Excellent. The final question with respect to wipes is someone brought up whether there's any concerns about availability of wipe supplies, and in particular the Kimtech wipes seem to be harder to find. Is that just a supply issue in our department, or is that sort of a more global supply issue?
So I can't really speak to the definitive supply of the Calgary zone or the province as a whole. I know that some of the other departments have experienced shortages or issues with, getting supplies. And what I have kind of recommended, and as per CSA standard, we need to be cleaning non-critical equipment with the low-level disinfectant as described in the manufacturer's instructions for use. And as this pandemic continues to proceed, we might not have that availability. So we might not be able to clean the right equipment with the right wipe. But what I would definitely still recommend is that we're doing the right level of cleaning. So we should be still ensuring that we have low-level disinfecting for all non-critical equipment.
Okay, I think that addresses all of the questions at this point. I'll hand it back to you, Stuart.
I just have one question in my inbox to speak to. Is that okay?
Yeah.
Someone asked me which is the preferential eye protection for when you're using an N95. And so I would still say the same principles. Make sure that you're picking the eye protection that fits you properly, that fits the procedure. Typically though, most people do prefer the medium length face shield when using the N95. They just find it more comfortable the way that, you know, everything kind of sits on the bridge of your nose. So there is no right thing to use because we're going to have to all be flexible and make sure that we're adhering to the principles. We'll see some unique combinations of PPE in the coming weeks, but we want to make sure that it's the principles that we adhere to.
And just to bring it up, there's lots of good discussion in the Q&A forum here around how to, what's the appropriate eyewear protection to wear and how to clean it appropriately. So there's been some good points there that will be shared in the question and answer document that gets sent out afterwards. So make sure to read that in terms of both cleaning them with the wipes as well as using soap and water afterwards to remove the film that can develop over time on them.
Okay, perfect. All right, guys, as usual, we're running late a little bit. I do apologize, but I'm going to get Sarah McPherson to do the wellness update now. Sarah?
Okay, awesome. Thanks, guys. So this week, I actually am going to delve into the topic of conflict resolution. As you know, this is a skill that's very commonly needed in our job as we are confronted with either mini conflict scenarios, sometimes major conflict scenarios. We find ourselves in these scenarios when maybe a patient has an expectation that we are finding challenging to meet, when there's differences of opinions between us and each other in the emergency, or sometimes between our consulting service colleagues. It's really important, though, to have effective skills in this domain because ongoing non-collaborative resolutions to conflict scenarios actually are a major contributor to the workplace-induced injury of burnout syndrome. And personally, I think most importantly is I really feel that this is an area that is eroding the joy of our work. For so many of us. And I find that really just so tragic, especially because having effective conflict resolution is all about skill development. So it's not something that you're just good at or not good at, it's something that can be learned. And I kind of personally experienced that about 7 years ago. A number of different things allowed me to see that I had limited skills in this domain. Some of you probably have been on the other end of when I have not been as successful as I would like. So I speak to you not as somebody who feels that they are an expert in this, but someone who realized that they needed to get better. I'm on a journey. I'm trying to become more skillful and practice. This weekend working, I kind of realized that we're in the scenario where this is becoming even more important. We're kind of in a more vulnerable state in so many ways, but especially with the pandemic where there's heightened emotion, there's rapidly changing processes where it's very difficult for everybody to have the same knowledge. There may be differences in ways things are communicated and messaged to different departments. We're going to be having people potentially redeployed into areas where they may not have the background skills and comfortability. And then we're also relying so much more on the telephone, which can make these conversations even that much more difficult. So from my perspective, I think we need to be consciously on the lookout for when we are in conflict scenarios, which are basically just when you see something differently than another person. It's not something intrinsically negative, it's just that difference of opinion. So be on the lookout so that we can bring our A game to the table. I actually think this is a huge opportunity for us to be building bridges and relationships so that we can all work together, even in these times of uncertainty. So what do you do? Like, how do you actually maneuver your way through? What are the skills that you need? This first slide reflects the number one, I think the golden rule of any type of conflict scenario is that you have to figure out a way that you can truly believe that the person that you are interacting with is smart, they're hardworking, they're reasonable, they want to do their best. This is the same thing that we do in simulation when we're debriefing, but it's so important that we bring that into our clinical work as well. This sounds super simple, but actually I think this is one of the most difficult things to recognize that we're not doing and to actually truly believe this about somebody else. So for me, I think about what are the ways that I can kind of figure out that I'm not doing this properly. And I'd say the biggest thing I've found is that if you can train yourself to be paying attention to any thought that goes through your mind, if anything goes through your mind about this other person that could have a negative connotation, I would assert that you do not truly believe the basic assumption. So these types of thoughts can be, this person is completely unreasonable. This person is so arrogant, they're difficult. This person is crazy. I've heard that said not infrequently about certain things. This person always does this, or this person never does that. These types of thoughts that go through our minds can be a nice little prompt to go, oh, wait, maybe I need to get myself in check. And how do I maneuver my thought life back to actually truly believing the best about this other person? Erin, if you could move to the next slide, please. So then the next thing that you have to do is the internal work, is what I call it. So number one is asking yourself, what do you really want here? So what is the goal? And I would say that for most of us, it's moving to the most optimal solution for all parties involved. It's incredibly easy to shift that focus to more wanting to have a few different other things going on. So the main urges to avoid would be, number one, wanting to win. This one, I think probably most of us have found ourselves in. This was certainly something that I still struggle with, but was struggling with more in the past. I realized, especially at Foothills, what I would do when I got some perceived pushback is I would increase my assertiveness level. And although that maybe gets you what you want in the moment, it actually is losing the overall battle in my mind, because when you do that, you're shutting down the other person who actually has something very valuable to bring to the table. You're also really risking the long-term relationship with that person. One moment of being angry or being more aggressive can really erode the trust that you've worked probably years to develop. And so that's why I'd say that strategy can be so hurtful. So that's the one thing, the winning. The next one, which I hadn't really thought about as much, but it's punishing. And probably there's a number of ways that this manifests. One is blaming. Another one can be making the other person look small. But I think the more insidious way of punishing is actually when we've had a conversation that we maybe didn't do all the work that was needed to hash it out and come to the best solution. And then we go and talk to our peers about that person, essentially gossiping. And what that is doing is it's punishing the other person by degrading them in the minds and thoughts of others. And I personally think that this is one of the most damaging forms of punishment that we do. And I know I have been very culpable that I have done that myself, and I'm trying to become better. It's very hard, but something we have to really guard against doing. The last thing is it can be really tempting to just go silent, that you maybe don't want to do the work, endure the sometimes discomfort that these conversations can trigger. But I'd say that the real reason that you don't want to fall into that trap is that you actually may be the person that has the knowledge, the perception, the insight to actually bring to the table that can help solve this problem effectively. So those are the three things to try to really avoid, and to also become more conscious of the ways that you may be doing this unintentionally. I know I was doing a lot of them without really realizing that I was, and being brought to my mind has helped me in the moment to not fall into those traps. The next thing internally that you have to do is trying to keep your internal story straight. Whenever we're interacting with anybody, we're bringing our own backgrounds, our perceptions, our values into trying to interpret the behaviors of other people. And in doing that, we can also very easily fall into certain traps. One of the biggest ones would be basically internally labeling yourself as a victim. And most of us probably wouldn't be like, oh, I never do that. Like, why would I ever do that? But if you listen to our conversations with each other, I would actually assert that we do this quite frequently. So ways that I think you can identify when you might be telling yourself a story that you're the victim is when you're hearing these types of phrases. Oh, everybody dumps on a merge. Other departments don't respect us for what we do. I'm getting pushback. Pay attention to how many times that phrase comes up in any given shift. It's very combative, actually. The next one that you can fall prey to is creating a villain in the other person. This, I think, really speaks to some of the tribalism that Miles was bringing up in his rounds earlier. But it's seeing the other person and assuming very negative things about their behavior. And it's also very easy to create villains of our colleagues. So saying things like, oh, they're always trying to block consults. Why don't they just do the work? Blah, blah, blah. Like these types of phrases can help identify when you might be creating a villain story of somebody else. The other one is the helpless bystander. Like, oh, there's nothing I can do. This is just the way the system works. That's kind of what we're stuck with. It's probably not what we're stuck with. There's lots of other solutions that might be more optimal that if we work together, we can find. Okay, Erin, next slide. So then the next thing, once you've done the internal work, you've assumed, you've got the basic assumption going for you, you've done the work to avoid these other pitfalls, then you can move into the basic formula. So basically, I'm just going to walk you through a very simple scenario that we face quite frequently. So number one is you need to kind of frame your concern. So what I'm going to walk you through is a scenario where maybe you're the third physician caring for a patient in handover. They've had a consult pending for the last 12 hours and a disposition decision has not been made. Okay, so now you need to have a discussion with the service that's been consulted. So what you could do is something like this. So you could go up to the consultant and basically framing it. So it'd be like, okay, you know, so-and-so, I'd like to talk to you about the consult pending on patient X. So then they know what you want to talk about, the consult that's pending. Next, you want to share the facts. This is not an interpretation of why you think it's occurring, and there's not any judgment being made on the other party. This is literally just the facts. So in a scenario like this, it would be something like, I see that a consult was put in for this patient 12 hours ago and a disposition has not been made. So you haven't shared what you think about it. You have not made any judgments as to why this is going on. It literally is just what has happened. And that's basically not refutable, right? Like these are just the facts. The next thing is that you want to share your interpretation. So you're basically just giving the story as you see it, but again, not commenting on why you think it's happening on their end. So we've already now come to this consultant and said that it's been 12 hours, a disposition has not been made. This is now the point where you can put in why you care. So you can be like, I'm concerned that this delay might lead to worse outcomes for this patient and is preventing the patient from being admitted to the ward. And because of that, then other patients who are unwell, are not able to be seen in a timely manner, and it also might be dangerous for them. Okay, so now, again, you haven't made a judgment. You're just saying why it's concerning to you. And the other person may also have the exact same concern as you. So now you need to open up, be curious, and ask to hear their side of the story. So you could phrase it something like this. This seems a bit longer than expected to me, and I was wondering what might be occurring that's leading to this delay in this case. Can you kind of tell me what's going on your side of things? Now, when you do that, you may inadvertently have triggered that other person, because it's a very normal human reaction to want to protect ourselves from perceived threats. Okay, so at this point you have to be really on the lookout, because the other person might get shut down, like they might just withdraw. They also might go on the offensive and get more assertive or aggressive. And then the other thing is they may get defensive, they may get angry. So it's really important in that time, when you've given your judgment of what's going on as you see it, and you're curiously listening and hearing their side, that you also are creating a zone of safety for them. So it's about being curious, tell me more. This is the time where you want to use empathy statements. So saying things like, I can see why this is upsetting for you. That must be really difficult. You're in a challenging situation. How can we work together? That type of statement can really go a long ways to helping that person feel safe and want to work with you. You also, in these moments, have to really believe what you're saying. So it has to be sincere, of course. The other thing you can do if you see that somebody is escalated and getting upset is just what we do with patients. Actually address it in a way that is non-threatening. So you can do mirroring statements. So someone seems upset, you can say, oh, it seems like you might be upset. Tell me what's going on your side of things. And then finally, you want to paraphrase your understanding of what they've said to make sure that you truly understand what their side of the story is, and that there's not that miscommunication. Next slide, please, Erin. So the final thing I would say is that there's some other phraseology that can really get you into trouble as well. So other pitfalls that you need to avoid. Number one, in these conversations, you might get triggered yourself. So recognize that and have a way to de-escalate yourself. You cannot go on with a conversation like this if you are triggered into anger, frustration, impatience, etc. Like you will not be able to believe the best about the person and move through constructively. Make sure you're not labeling the situation. We've talked about that. But then also refrain from using statements that are emphatically dichotomous. So using statements like, you're wrong, this is absolutely incorrect, that's ridiculous, that's not how it is, always, never statements, actually shut the conversation down. So instead, there's slightly different ways you can say the same thing. So instead of saying, you're wrong, you can say, I think I might see things differently. Let me describe how I'm seeing it. Or instead of saying, this is the way it is, say something like, my understanding is. It leaves that slight opening that the other person is invited to the conversation and dialogue, as opposed to shutting their voice down. All of these things they're just subtly different, but can make a really big difference in our interactions amongst ourselves and with our colleagues from other services. And I'd really challenge you, as you move through your shift, to pay attention to see how many of these mini conflict scenarios you can actually find, so that you can start practicing your skills in a more conscious way. Just like we practice our skills to get us prepared for difficult intubations, we need to be practicing our skills all the time, so that when we find ourselves in a challenging conversation, we've got the skill level to be able to manage it effectively. The more we practice these scenarios, the better we will be at managing our conflict and moving to a more collaborative working environment. anyways, that's what I've got today. Hopefully it was helpful, and you can put that into practice. I know I'm continuing to work on it, and you can call me out if you find my skills lacking. I also just want to highlight again the resources that can be helpful for you: the peer support team, the physician and family support program, the numbers on the slide, also inviting you to join the Slack channel. All of these things can also be found in the weekly newsletter. All right, thanks everybody.
Okay, thanks Sarah. Please can we move on to the next slide, Aaron? All righty, so let's just wrap this up. April 16th, next week, we're looking at disposition decisions and outpatient management of a COVID-19 patient in the COVID-19 era. Just want to thank Dr. Conley and Kat for joining us. I think their input was really, really helpful. And then please send us any questions or topics that you would like to see covered. I think we're just going to wrap that up. Thank you very much to all the working group members who participated and who helped with this webinar. Bye-bye.